This is Dr. Radio. Coming up next, from the heart of the NYU Langone Medical Center, in-depth coverage of today's health headlines. This is Dr. Radio Reports.
Welcome to Dr. Radio Reports. I'm Dr. Siegel, Medical Director of Dr. Radio, Professor of Medicine, NYU Langone Health. I'm back from D.C. today. I'm really tired. I actually am back in the studio in our lobby at NYU. Very glad to be home. I followed the smoke down south to D.C. I mean, literally, I left New York cleared. I went to D.C. It was a cloud. Got back here. It's clear. And, you know, I've been advocating on TV about staying indoors and wearing proper masks, which is at least a KN95. It looks like we're not. I don't think the United States is out of the woods with this yet, but New York City right now is looking really good. So it depends on where you are. Unfortunately, there was a lot of crazy pushback from lunatics about, you know, whether this smoke is of public health interest or not, and of course it is. And the particles that were involved are very, very tiny, can get into your lungs. I talked to our own Frank Adams about this, who wrote the Asthma Source Book and is a host of our shows, our pulmonary show on Tuesdays from 6 to 8 a.m. Eastern Time. Tremendous resource for me for many years, especially with asthma and COPD, and he was making a lot of great points to me, one of which is lower respiratory tract infections could have been provoked by this. Asthma, I was telling people to take an extra inhaler. Of course, I can't give advice to people that aren't my patients, but it was wise to take this seriously. I saw somebody on a bridge running without a mask in Philadelphia the other day under a cloud of smoke, and I thought, well, let's hope they're in really good health. They probably are. Speaking of really good health, my first guest, Dr. Paul Pipia, I have known for many years. In fact, we talked to Steve Flanagan last week about the legendary Siegel rounds at Rusk on Friday mornings with donuts and coffee. That's the only way I got anybody's interest in those days. And one of my star students for that time was Paul Pipia, maybe the best resident that I ever taught, clearly in the top handful. And another one, of course, was Jonathan Whiteson, who hosts for us on Mondays, the Rehab Show from 6 to 8, another all-star. But to my great satisfaction, I found out that Paul has risen through the ranks to be a very highly ranked public health individual here in the state of New York, which of course I have zero to do with it, but nevertheless, the cream rises to the top. Dr. Paul Pipia, president of the Medical Society of the state of New York, elected April 22nd, 2023, chairman of the Department of Physical Medicine and Rehabilitation, as well as deputy medical director of the Nassau County Medical Center. Paul, to what do you owe all of this success?
I have to go back to the time that I remember when you were consulted on one of our patients, and I will tell you the patient had pulmonary embolism. You recognized it right away and took action and saved the patient's life. So I always remember you for that. So yes, I am the president, the 197th president of the Medical Society of the State of New York. We started in 1807 when Thomas Jefferson was the president of the United States. And we're before the AMA. Right, because all these states got together and then formed the AMA. So the thing that I'd like to talk about today is the wrongful death bill that was signed, also known as the Grieving Families Act. Last year, this was passed overwhelmingly. There's 150 assemblymen and 63 senators, and all but 8 last year voted in favor of this. The governor took a lot of courage and vetoed the bill and gave a lot of explanations why. And the reason is no one was really understanding how much this was going to cost, what this was going to do to people in the state, and it also adds municipalities. And basically this law was passed because of people who were drunk drivers who drove the wrong way on the road, and somehow the doctors got lumped into this. But there's a lot of people who have been looking into this. Haney's, the medical liability insurance companies, many of the insurance companies are all like that, and also individual counties. And I'm talking about municipalities. If there's a crack on a sidewalk, it greatly expands things that happen. So the Senate and the Assembly went back and trying to do, the best for the grieving families, who we understand people lost somebody and they need to be compensated economically for it. We understand all of that. But the problem is, in New York, if you look at where we are in payouts, last year New York paid out $1.4 billion in malpractice payments. The second highest was Florida at $728 million. So roughly, we're twice the next competitor. And then Pennsylvania is a close third with $720 million. So if you do this, we think that it will increase, and there was a study done by Millman, we think that it will increase the malpractice rate on insurance by 40%, which we think is untenable for anybody. So those are the things we're in there, and some of the things that. Go ahead.
What does the bill actually do, though? What does the bill that you're talking about actually do? From a patient point of view.
Okay, so the statute of limitations. Well, here's what will happen. The statute of limitations was 2 years, and now they're increasing it to 3 years. And then they're increasing the number of people, close relatives, who can sue. It also tries to eliminate a law that was many, many years old, and it valued people by how much they were worth or if they were working and what their ability to earn was. So they tried to get rid of that, but also then they increased the amount that people would have to would have to pay, and how it would hurt the society. So specifically, if you increase the rate of malpractice, you're going to have people leaving the area. People are going to not take on cases that they think are a little bit of concern, things that are, cases where they say, maybe I'll just pass on this in case something happens to them. So it will do a lot to discourage physicians from seeing patients, and it'll start to chase physicians out of New York. That's if the
bill passes. You're saying that the bill it passed, and you're saying that the bill will increase liability on physicians, and will make them avoid cases of patients that are very complex and have high risk of failure, right?
That's correct. Look, there's been a lot of exodus of people out of New York and physicians as well. But when your malpractice insurance goes up by 40%, you don't pass that on to anybody. And what happens is people will just leave the area. And the people who will go first are the physicians who predominantly take care of people who are in the lower insurance things, such as Medicaid, which doesn't pay a lot of money. And the Medicaid people, they'll be at the same risk. So what will happen is the physician will say, listen, this is not worth my while doing, and I'll just, stop taking Medicaid, which will decrease the people who can use it.
This is a great point. Let's get into the weeds on this a little bit. This is my week for comparing California to New York. I've been comparing wildfires there with wildfires here, and I actually have on 2 California experts next week to join me on this. One, Mark Morocco, a very close friend of mine, and one of the heads of the ER at UCLA. I'm going to say, hey, what's a wildfire like there versus here? And I have some of the answers already. But how about Medicaid? I have a sense, looking 3,000 miles away, that Medi-Cal is pretty good, that somehow they figured out how to use Medicaid in California to help patients with an extensive backup, I guess, and services without hurting doctors, but not so here. How do we, or maybe same here, how do we compare Medicaid here to Medicaid in California?
Okay, well, I'm sure in California they get paid a lot more than we do, but Medicaid here in New York was reimbursing doctors about $30 for a visit. I guess if you get a couple of coffees at Starbucks, it would be higher. Now, over the year, we have been, being successful in getting the state, the governor and the Senate, the Assembly to increase the rates, but it's not enough, and it's not going to keep up with it. The other piece that California has over us is they have a cap on non-economic damages of $250,000, and there's no cap here in New York. We've been fighting, the medical society has been fighting malpractice insurance reform for at least as long as I've been a doctor, and that's like 38 or 39 years. So that's a problem right there. if you can't solve that problem, it's just so much easier to go to another state where it doesn't happen. Now, I'm not leaving New York. I've been here my entire life, but it is a concern to everybody.
Paul, let me ask you a fundamental question, because I know you as a really caring doctor, and I'm a big believer in controversy and in debate and back and forth. I like things that are edgy, right? And nobody else does right now in the country. This is my gripe. Everyone sticks to their position and tries to just get followers to their position. I like a back and forth. That's why when it comes to COVID origins, I have people on about natural origins. I have people on about lab origins. I try to cover different things. I'm going to tell our listeners you're one of the most caring physicians I know. And it also comes from your own background, which I won't get into. But so I get, though, that today on the radio with me, you're being a doctor's advocate because you feel that doctors, with the expansion of something like the Grieving Families Act, are getting more and more liable for things maybe they have no control over. How can you be both a patient and a doctor's advocate?
Okay, so let me tell you how I'm a patient advocate on this, all right? And maybe the way I presented it wasn't the best, but the thing is this.
No, you're fine. You're fine.
If you lose great physicians who can take care of people because they go someplace else, then that's not helping patient care, all right? And there's a lot, like from my own standpoint, right? My entire career, I've taken care of patients that were economically disadvantaged. And I worked at Nassau University for over 20 years, and I worked at Downstate in Brooklyn, where we served the poorest of the poor. So in those cases, if you lose people because of these other induced costs, and you're losing physicians who could help. Try now, even if you have regular insurance, try now to make an appointment to see somebody at one of the big hospitals. And you tell me, and you might know this, how long does it take to get somebody in? Now, obviously, physicians will always make room. Physicians will always make room for somebody who has an emergency, right? And the emergency room is always the stopgap to help take care of patients. But if you want to come in and see somebody for just a regular checkup, that's not happening in 2 weeks, 4 weeks, or better. One of the doctors that's out in Nassau, he's a neurologist. He said they're looking at 6 months now. So that's
true here too. Many visits are 6 months here. Depends on the person. As you said, emergencies. I can use my pull to get people in. Other people can. It's not the doctor's point of situation. It's the whole situation of structure, and not that it's a bad structure. I mean, we have a great structure here. And in fact, the group practice is great, but there's an overflow of need. There's no question about it.
Right. And so if you look at New York, trains probably about 15% of all the residents in the country. If you look at 50 states, you could say 2% for each state. Now, that's not true because New York and California and other states are more populated, but we train 15% of the residents, and most of them just leave. They get jobs outside. Residents, have come up with the thing that they have to, they have student loans to pay and everything else like that. But I mean, it's a patient access issue, and that's why we try to advocate for our patients.
Let me go into something I wasn't intending to bring up, but this is a fascinating discussion, and I like your honesty and I like your clarity. So about 2 or 3 years ago, no, maybe 4 years ago now, right before the pandemic, and I'm going to get to the pandemic in a minute, I went up to Dunkirk, New York, which is under your, you're the whole state, right? And I interviewed people at the Federally Qualified Health Center in Dunkirk, the Community Health Center. And I was actually very, very moved by how much they've expanded services with the help of the Affordable Care Act. It changed my view of the Affordable Care Act to some extent. I'm a big critic of it, as you know, but I am not necessarily a critic of the Medicaid expansion, and I saw it work. But they didn't have doctors. So they had services, but they didn't have doctors. The doctor shortage was ridiculous there, and the nurse shortage was ridiculous there. I'm bringing up this model because of what you said about Medicaid. So maybe the clinics are one answer to that, but they still lack the doctors. Your thoughts on this?
Okay, so that'll actually lead me into scope of practice in a minute. But here's the problem. That they provided a lot of money and kept a lot of distressed hospitals afloat. I have to tell you this, the governor, to her credit this year, put $1.2 billion in the healthcare system for distressed hospitals, and the Senate and the Assembly added another $500 million. So there's $1.7 billion approved in the budget to go out to take care of these places. But still, that's not enough when you feel that you're under the gun all the time. So the state is trying to do their part, and we do very well with the state. The state has helped us out, but there's also sometimes where they pass things that we disagree with, and they understand that, we understand that, and we're on a very good dialogue with everybody. But I going back to wrongful death, I think it's important. Now, scope of practice, if you have a minute to go into that.
Of course.
There's a lot of so scope of practice is a tough issue for us. Now, there's a lot of members of the Allied Health team.
By the way, before you start, tell us what scope of practice is, and then
Okay.
Go on.
All right. So the scope of practice that I'm interested in right now is that people get to the state is looking to pass and give people that are other healthcare workers, such as nurse practitioners, physician assistants, and even pharmacists, the right to treat patients independently of having physicians oversee what they do. And the problem is this: is those regulations got relaxed. They got relaxed during COVID because everybody was on deck. I mean, I'm sure your hospital did what my hospital did. Ophthalmologists were seeing patients, right? Even the rehab residents were seeing medical patients, and were covered by all the medical teams. But you went from a hospital that had units filled. Everybody had to expand. I mean, I think that the whole state, all the physicians and the Allied Health members all stepped it up. However, the scope of practice now is they wanted to have physician assistants have the right to treat patients independently of a physician watching over them after they had 8,000 hours of experience. Now, my residency was 16,000 hours, so that's, so you're letting them take half. And then the other piece is this: there's nothing that stops a physician assistant, a nurse practitioner, or anybody else, a pharmacist, to quit their profession, go to medical school, and become a physician. It doesn't like. Well, I'm sure you still train residents, so now there's things called milestones, right? And the residents have to progress through the different milestones. So some is just a history. I'll give you an example. Some is a history and physical. Then the next level up is a history and physical with complex medical cases. Then a history and physical with complex cases and a differential diagnosis. And then the next level above that will be a case with an extensive differential diagnosis and alternatives in treatment. And all of those things are done, and the residents have to go through that now.
But
who's going to do that for the physician assistant?
Well, by the way, there's 2 points I want to make. One is a joke, which is I was thinking, as you said, the milestones, that they're going to put Chat GPT through that next and see where they go. But that's a joke. But the next thing I want to tell you is I don't want you to come across here as someone that, because you're too compassionate. You're not saying, and you could disagree with what I'm saying, you're not saying. I don't think you're in any way trying to put down nurse practitioners or physician's assistants. You're talking about autonomy and what role they play within the healthcare scheme, right?
Yeah, that's correct. From my standpoint is, listen, they're all valued members of the healthcare team. There's doctors in many practices in the downstate and the upstate areas that could not survive, and I say that sincerely, could not survive without the physician assistants that help them and the nurse practitioners that do that. But in the end, there's a doctor that's responsible for making sure that they look stuff over and they have stuff to bounce people off of. My concern is if I didn't say it the correct way.
You say it the correct way. You're saying it the correct way. Relax. You're doing great. Go ahead.
Okay. All right. So, we want to make it. Think about it this way. There's minute clinics that are opening up in pharmacies, and then the patients go right over and get medication, right, from the pharmacy. That's a great thing for them. But in your office, if you wanted to give out more than a 3-day sample of medications, you can't do it. right? And you're the physician. So, I'm concerned about that. They allowed pharmacists to do simple vaccinations for flu, with a general order because there was a lot of people that needed to be vaccinated. But what I'm interested in saying is I want to maintain the quality of care for the patients by having a doctor lead the healthcare team. So the healthcare team can have nurse practitioners, physician assistants, pharmacists, and they all have their role. But when they're asking for a role that's bigger than what their training is, I think that that you have to say something. And I guess that's the clearest I could make it.
That's beautiful and very well said. Paul Pipia is with us, president of the Medical Society of the State of New York. He's been there for a couple months now, chairman of the Department of Physical Medicine and Rehabilitation Medicine, well as deputy medical director at Nassau County Medical Center, trained here at NYU at Rusk Rehabilitation. I was responsible for a couple of donuts, probably added a few pounds to them. Give us a call at 1-877-698-3627. I'm referring to my donut rounds that I used to have every Friday with the rehab residents, and he was one of the best I ever had. Give us a call at 1-877-698-3627. Paul, talk to me about what you do as president of the Medical Society of the State of New York. What is your role?
All right, so later today I'm going to be flying out to Chicago to attend the AMA meeting. And one of the nights that's there, they have all of the presidents of all of the state medical societies. I also go to the different societies, the county societies. Last night I had to do a videotape for Westchester County because I couldn't make it out to that. I've attended the Queens County. I have very close relationships with the people in Brooklyn and Manhattan. And so what we are supposed to do is the House of Delegates is once a year. And when the House of Delegates is not in session, the president, the council, the executive committee, and the board of trustees try to run everything. So what we try to do all the time is to advocate. So this year we advocated for an increase in the tobacco tax. We also tried to ban flavored vaping. Now we were on top of all of that stuff. We're trying to get the state to pass something called a gold card for authorizations. So every time you want to do a procedure, you got to get prior authorization. So let's look at an orthopedic surgeon as an example. And let's say 90% of their hip replacements get approved with prior authorization. So for the next 6 months after that, if you had a gold card, you're able to not get prior authorizations. I mean, recently, one of the insurance plans wanted to make it that you had to get prior authorizations to do a colonoscopy or an endoscopy. And those type of things put extra time, burdens the system. You have to get on a phone. You have to pay somebody to get on a phone and try to convince somebody on the other end of the line who has never seen the patient to see if they need to do it. And, it's, a lot of that is probably done by the insurance companies for cost containment. The cost containment is important for them. They want to make sure that they don't use up too much services, but also we have to advocate for the patients. And that's so those are a couple of things right there. We also were helpful this year, and it won't take effect until later. If an insurance company goes under, like what happened with Health Republic a number of years ago, all of those doctors had, and the patients were not covered anymore. So those patients had no insurance. And so what happened is this year, and it'll take effect later in the year, is there's going to be a guarantee fund. So if an insurance company goes under, a health insurance company goes under, there'll be funds there to help take care of those patients so that they're not left with any other specialty. So the things that I do is like I put in now some op-ed pieces in different newspapers. When they do stuff, we're submitting today something to Newsday for their story that they had the other day on the wrongful death suit. It's a lot of times taking up the stuff that takes place, and I get calls from members. My cell phone number I give out to everybody in the society, and people go, why don't you give it to a secretary? And I said, I'd rather them to get me in touch whenever they need to get me.
That's what I know about you. Yeah. By the way, can you talk to me about how the Medical Society of the State of New York has dealt with COVID and post-COVID, the post-COVID world. I hate to use the term post-COVID, by the way, because it's not really a medical term because we still have plenty of people getting sick from this virus. But talk to me about the role of the medical society in dealing with COVID and dealing with the aftermath. That's a good one of COVID.
Okay. So we, by the fact that we have so many members, we had a lot of people in infectious disease that were able to help, help put forth the policies, and we're there in case anybody needs us for the vaccination advice, and so we have a whole team of infectious disease that we use, and they're around the state. Sometimes we weren't contacted, but other times we are. We were early advocates for the vaccination in the beginning to make sure that people got vaccinated. We established our own method so that physicians could get PPE when there was no PPE, and that was done by a president 2 years ago to try and make sure that everybody had PPE. And that president was Bonnie Litvak, and she was from Westchester County. So there was a lot of stuff you couldn't do. You couldn't see patients. So we are now in a position where we know that the post-COVID world is never going to be the same. I mean, if you look at stuff that happens now, most people only work 2 days a week, 3 days a week in the office, and the other days of the week they're at home. And that's a big economic problem for the entire state. So we are there to help. We've given seminars, we've given education sessions to everybody. So we have the ability to do that. I hope that answers your question.
Yeah, in a big way. Final thoughts. Final thoughts of where we're going, and maybe even focus in this last answer about healthcare disparities, because I think you made a point earlier. You've had many roles in life, and one of them is treating a lot of poor people that need rehab. And we're talking about people that have had strokes, people that have had injuries, people recovering from surgery, people with disabilities. We're going to talk later in the show to an expert in Ehlers-Danlos. I mean, you've been there on the front lines, and that's what I meant when I called you such a compassionate physician. Where are we going in New York in terms of dealing with healthcare disparity?
Okay, so it's a very complex issue. We're right there. The Senate, the Assembly, and the governor all want to help people, and they all want to help with healthcare disparities. The question is, how do you actually get there? And that's the tough point. Physicians, have big loans from school. So one of the things that they have, New York has, is something called Doctors Across New York. So if you go to an underserved area, the state will reimburse your tuition, not fully, but I think it's $10,000 a year for the years that you do that. So that's one way, right? I always advocate, and we in my hospital, because 70% of our people are underinsured at the Nassau University Medical Center, and we take people and we rely on the fact that there are some programs in the state to do it. But DSRIP was out there. We got a lot of money from DSRIP. The COVID money that was out there helped us do a lot of things for a lot of people, and now all of that money is disappearing. And so since that money has disappeared, you have to rely on the fact that people will do goodwill, that doctors will go out there to do that. And I advocate for that every single day, and I practice that because that's what I do in the hospital that I'm at. I never ask what somebody's insurance is unless I have to get approval to get them an MRI. And many times the patients are self-pay, and the hospital has a sliding scale for people that are self-pay. So we're there to try and help.
And I know that about you. Dr. Paul Pipia, what a treat to have you on today. Again, someone I recall very well, know for many years, Paul Pipia, president of the Medical Society of the State of New York, just been in that amazing role for 2 months, chairman of the Department of Physical Medicine, Rehabilitation Medicine, deputy medical director of the Nassau County Medical Center, near where I grew up. And you made a really good point towards the end. I was thinking when you said that, if everyone's at home a few days a week, maybe they can at least make a salad. But, you know, the economy actually is based on people being physically at work, right? So that there's so many manifestations. Dr. Pipia, thank you so much for joining me on Dr. Radio Reports today. I hope you'll be able to come back soon. I'd like to see you regularly. Really a great treat for me.
Anytime. You guys have my number.
We will be in touch. We'll be right back.
Thank you very much for all the work. Bye.
You bet.
Never miss a beat of Dr. Radio. Dr. Radio. It's available on the SXM app, including